Good afternoon, all. Can you hear me? So I'm Siriorn Watchanaranan from Bangkok, Thailand. And it's my pleasure to join Symposium today. And I just want to thank the organizer for inviting me to speak today. This is the outline of my talk. I have no disclosure. And I was just going to begin my talk on outlining the parasitic infection in Asia. And then I'll be touching based on the timeline of infection after organ transplant. Then I'll be moving to parasitic infection in transplantation. I'll be talking about the 4 modes of transmission. Then moving to intestinal parasites, Bronchoscopy, and common protozoa. And then I'll be talking about common tissue protozoa in transplantation. And lastly, I'll be talking about pre-transplant screening and post-transplant monitoring. Next slide, please. So parasite infection is one of the neglected tropical diseases which remain prevalent in Asia. And you can see in circle where we are, the range of the neglected disease from 1 to more than 5 types of the infection. Next slide, please. Next slide, yeah. So the magnitude and scope of this burden varies for each of the parasites. And on your right hand, you can see something that you're probably not familiar with. Some of the patients had their illness and be cured by their local doctors using kind of leaves, fresh leaves. And the second pictures is the type of the food, and perhaps it's the eel and water eel, and you can see that the parasites also in there. On the right lower picture is the food that actually also quite common in Thailand, is the fermented fish that is most quite famous in northeastern part of Thailand, and this brings up to many types of the parasites that has been seen. So in Asia, there are several types of the infection, and mostly ascariasis, trichinosis, and also hookworm. But for global, we can see that the burden of the disease may be different. For global burden, one can see that liver fluke and intestinal parasites are prevalent. Next slide, please. This is the slides are very important to those who practice transplant infectious disease. We usually divide the phase of infection in 3. One is the early post-transplant, less than 1 month, and 1 to 12 months, and also more than 12 months. And you can see here that if one risks themselves for infection, they have to consider several things. For less than 1 month after transplant, hospital onset infection and also infection related to technical surgery is also play significant roles. However, donor and recipient risk of unrecognized infection or previously untreated infection also very significant in early post-transplant. For 1 to 12 months, one can see that if you see the red circle or the red square, parasite infection can start to be seen about in the 2nd and 3rd phase. Next slide, please. So infectious disease in the transplant patient may run a different course with a shorter time to development of disease and a greater associated morbidity and mortality than immunocompetent patients. Next slide. So suspicious of parasitic infection in solid organ transplant require insight in the clinical manifestation and knowledge of the 4 modes of transmission. This is actually well known in transplant infectious disease. One is donor-derived disease. 2nd, reactivation of the infection. 3rd is the transfusion-mediated. And 4th, de novo infection or newly acquired infection. Next slide. Increase in migration and international travel have also led to a rise in the number of donors from foreign countries, and this linked to an increase in the risk of the infection from specific area of the world, which may persist in latent and or chronic form in the donor and may be transmitted during transplantation. Next slide. This is the first case in our hospital. It's been like 10 years ago, but I think it's very interesting to share with you. 49 years old man underwent kidney transplantation in 2011. He had end-stage renal disease and he had been okay until like 4 years after transplantation. He presented with fever, abdominal pain for 1 day. Then he rushed to emergency room and diagnosed with acute appendicitis. Then he had the appendectomy, but then a day or two after transplant, he had fever, and ID was consulted to be on the case. History of abdominal pain and chronic diarrhea for a while before the presentation. This is the finding from the appendix. One can see edematous and congestion with the numerous eosinophilia and plasma cells infiltrate. There were also few granuloma in submucosal layer. Next slide. So I want to ask you all, from stool examination, which one of the organism is likely the cause of the illness? You can see that there are several larvae in there. There are few eggs, and you can see that hard shell eggs, bigger size, probably not the cause of this illness. But the 3 larvae is interesting when you need to differentiate between the type of the larva, whether it is whipworm, hookworm, or strongyloides. Next slide, please. Next slide. Yeah, okay. For this case, stool examination show viable larva of Strongyloides stercoralis. Patient was treated with 2 days of oral ivermectin. However, treatment has to be extended because of the ongoing of the symptoms. But after about 1 week more of the treatment, he had resolution of symptoms, and there were no relapse of the parasite in the stool, nor eosinophilia until 1 year after transplant. If you see in the table I list for you, he actually had a bit of eosinophilia without clear cause about 2 years after transplant. At that time, there were no document of any symptoms. Next slide. Next slide. This is a second case of 49-year-old woman who had kidney transplant in 2009. Then she presented later with weight loss, abdominal pain, diarrhea, vomiting, and rash. Post-transplant, she had a poor graft function and was diagnosed with acute rejection about 5 months after transplant. She was treated with pulse methylprednisolone, and then she was changed to maintenance immunosuppression of high-dose steroid, prednisone 30 milligrams per day, and then MMF of 1,500 milligrams per day, Prograf, and INH. 10 days before her presentation, she had progressive shortness of breath and diarrhea. Next slide. This is physical examination. Her pictures is not illustrated, but this is the pictures of other patients in the idimage.org. So she didn't have any fever, but she had sign of heart failure. Next slide, please. Bronchoscopy was done. And before the bronchoscopy, X-ray showed that she had pulmonary infiltrates on the right-hand side. Left hand is her X-ray as baseline. You can see that she had bilateral pulmonary infiltrates during the admission. Next slide. So this is her bronchoscopy, and this is the direct Gram stain of her BAL. On the right side, you can see there's larva there. And looking at her blood agar plates and also chocolate plates, it's very interesting to see the movement of something on the colonies of her bacteria. So this is, again, strongyloides. This is disseminated strongyloides case. Next slide, please. So Strongyloides stercoralis is the soy-based helminth found in tropical and subtropical regions. And I find this, I want to have some attention or focus on this Strongyloides case because it's quite prevalent in our area. So, so far, over 300 million patients are affected worldwide. And the manifestation of infection can range from asymptomatic eosinophilia in immunocompetent patients to disseminated disease with septic shock in immunocompromised hosts. The possible organ involvement can be skin, lung, or GI tract. And with the GI tract, one can see duodenitis, diarrhea, or ulcer-like symptom from the finding. Next slide, please. This is a skin manifestation of strongyloides, and not only for competent hosts, but also for compromised hosts. You can see ground itch or the larva penetrating into the skin, which cause inflammation and edema. And sometimes you can see urticaria tracts as well. It's severe pruritus can be seen. For chronic infection, one can see what they call larva currents or urticaria, pruritus, or dermal migration. For hyperinfection, it's generalized petechiae as shown in previous case, but it's rather uncommon. Next slide, please. This is Brazilian experience, and on your right-hand side is the table showing that when patient was diagnosed with strongyloides in this series based on the symptoms and also identification of the larva in clinical specimen, it showed that the most common type of the clinical presentation is the GI symptoms with the epigastric pain as a major complaint. And you can also see respiratory symptoms in about 40% and also GI or respiratory symptom in about 43% of case. Only about 30% had fever and about 43% had eosinophilia. Or typical upper umbilical lesion were infrequently noted. Next slide. Move on to the next parasitic infection. Besides strongyloides, Giardia, Cryptosporidium, Entamoeba also had a worldwide distribution and is prevalent in developing region of the world. Ascaris and schistosomiasis are seen in our regions, but they are not opportunistic infection after transplant and do not differ significantly from infection in immunocompetent patients. Next slide. This is a survey of patients in Thailand. It showed that in Thailand, Opisthocus viverrini and strongyloides are the two most common type of helminthes seen. Next slide. Intestinal protozoa, moving on. We just talked about protozoa. We just talked about strongyloides. We are now focusing on protozoa. Protozoa are actually seen in developing countries and can be transmitted to humans via contaminated food, water, and zoonotic exposure. There are a variety of the pathogens, including Cryptosporidium, Cyclospora, Cystoisospora, and Giardia. But in terms of immunocompromised hosts, I would say Cryptosporidium and Microsporidia can be life-threatening and are very important. And this microorganism can also be acquired via intestinal transplantation. Intestinal amoebiasis, balanidiasis, and giardiasis are also can seen in transplantation and mostly were diarrheal illness, but not quite pathogenic. Next slide. This is the example of case. There were 3 patients who underwent organ transplantation from a donor who about in the mid-30 woman from Mexico. She actually passed away from subarachnoid hemorrhage. And after transplant, the first patient, the lung transplant recipient, had fever about a week after transplant. And then about 3 to 5 days later, the 2 kidney transplant patients also get sick, and 1 patient died. Next slide, please. This is the tissue or post-mortem tissue biopsy from one of the kidney recipients who died. And you can see on the left-hand side, there are multiple microabscesses seen at the renal capsule. And on the right upper on the right side of the picture, you see the cluster of the mass of the Microsporidium inside, which is stain positive also from immunohistochemistry. On the right, you see microscopy, electron microscopy of the Microsporidium. And on the last 2 pictures, you see they were actually not only kidney, but also the Microsporidium also infect other tissue and throughout the bodies. Next slide. The next case is a 52-year-old man who had liver transplant secondary to hepatitis C infection, but the first transplant was rejected and he required a second transplant. He was well until about 3 years later, and he presented with diarrhea, severe dehydration, but the diarrhea has been 3 weeks onset. He also hypotensive at presentation, and he also complained of pruritus. Stool was negative for Clostridium difficile and ovine parasite, and CT of the abdomen and pelvis showed edematous of the stomach and ileum. Next slide, please. Because of the diarrhea, EGD was done, and the tissue biopsy showed the numerous organisms of the Cryptosporidium parvum in the stomach, and also change consistent with the infection of the colon. Because alkali ALT was also high, up to almost 600, liver biopsy was also done in this case and showed the presence of the organism in the ductal epithelium. Next slide. What I have shown you were examples of cases that suffer Microsporidium and Cryptosporidium after transplantation. Microsporidium is very challenging because the diarrhea is, although it's the most common presentation, the Enterocytozoon nuclei, which is resistant to treatment, is the most common encountered species in organ transplant. And dysentery disease can be seen. And for Cryptosporidium, diarrhea can be lethal, and patients can suffer from malabsorption and weight loss as well. Sclerosing cholangitis has been shown as example in this case, the case I just showed you. Next slide. This is the slide from CDC showing that there are more than 15 Microsporidium species identified as human pathogens. Next slide. This is a diagnostic strategy. This is for Cryptosporidium, and diagnosis can be made from the stool. One can do direct immunofluorescence staining or PCR testing, but keep in mind that although trichome stain is easy to find, it's actually not a good test to is inadequate to have to show the definite diagnosis because sometimes the oocyst is not well stained. And show here on the left hand side of the picture that in the red arrow is the oocyst of the Cryptosporidium, but the blue arrow is the yeast, and you can see that it's a little difficult for those who are not familiar with the organism to identify the organisms. On the right side, organism can be identified by Cilius staining as well. Next slide. For Microsporidium, it's a bit more sophisticated. You need a chromotrope or a chemofluorescence stain or immunofluorescence staining for identification of the Microsporidium. We can also do PCR testing for that, but it's not always simple. Next slide. This is Cyclospora and Isospora or Cycloisospora. It is actually not too hard to identify using modified Cilius or safranin stain. Also, you can do fluorescence staining, but because of the intermittent shedding of the oocyst, one need to do multiple testing of the specimen, and also you need to also consider concentration methods for diagnosis. Next slide. This is the picture of the Cryptosporidium with the smallest size compared to the Cyclospora and Isospora. Next slide. This is a milestone in the stool testing for diagnosis of diarrhea. I want to show you that we've come all the way from nothing to until now. We have GI panel, which is FDA approved in 2013. Next slide, please. For GI panel, one can see that they are commercially available, and even they are commercially available. Microsporidium also not included in the panel. So when we test for the GI panel, one need to consider that not all the organisms that cause the diarrhea is included in the panel. You need to have more testing for identify the organisms. Next slide. This is the example of the application of diagnosis for severe diarrhea in kidney transplant recipients. When they use molecular technique to identify the organism, they pick up a bit of the organism, including Giardia and Cryptosporidium from the PCR testing. Next slide. This is a recommendation. It's quite useful, and it actually goes along with what I just mentioned in the CDC reference that I just showed you in the previous slides. This recommendation can be found in Clinical Transplantation 2019. This is regarding the diagnosis and stool testing. Next slide. Again, for Giardia and Microsporidium as well. Next slide. For small bowel transplantation, this is quite unique and is risk for parasitic infection because of the length of the immunosuppression and intensity of the treatment. Intestinal protozoa, including Microsporidium, Isospora, and Cryptosporidium, has been identified. Next slide. This is a therapy of the common parasite infection in solid organ transplant. And again, you can see in the Clinical Transplantation 2019. Next slide, please. again for the treatment of the strongyloides. Just want to show you that for strongyloides treatment, we've been doing a lot in Thailand. We do serological screening pre-transplant, and we've been treating patients pre-transplant when they are seropositive for strongyloides. We have few cases of strongyloides post-transplant. We also treat them with ivermectin as well. Next slide, please. Moving on to the next one, which is the protozoa infection. Next slide, please. For protozoa infection, I want to focus my talk to 3 of the organisms. One is the Toxoplasma gondii. Next is the Trypanosoma cruzi or Chagas disease, and Leishmaniasis. The top 3 was the one that actually quite important and life-threatening. They can be seen within 3 months after transplant, but mostly donor-derived. But also they can be diagnosed 3 to 6 months after transplantation, but mostly were reactivation of the disease, and particularly in those who had intensive immunosuppression for rejection. Heart transplant patient poses a specific risk for the infection, particularly the Chagas disease and Toxoplasmosis. Next slide, please. This is an example of the Chagas disease. A lot of you probably not familiar with this because we are not in the area with the prevalence of the disease. This is a Romana signs of the primary inoculation of the infection. You can see the typical swelling of the eyes or some of the indurated area when the insect was bite. Next slide, please. This is Chagas disease. There are 3 clinical stages from acute, chronic indeterminated, or chronic determinated form or reactivation in immunocompromised host. Chronic indeterminated means that chronic asymptomatic infection. For chronic, the determinated form is chronic symptomatic infection. Next slide, please. For reactivation of infection immunocompromised, you can see myocarditis, CNS involvement, and patient can be really sick for that. Diagnosis can be made from PCR of the blood as well as smear from the blood. Next slide, please. Chagas in transplant is very complicated, and reactivation of acute Chagas disease after heart transplant for Chagas cardiomyopathy heart disease occurs in about 40%, and typically asymptomatic, but you can see patient presented with fever or subcutaneous nodules of the Chagas subcutaneous nodules. They're probably going to be an early manifestation of the reactivation of disease, and the risk of the infection increase with the intensity of immunosuppression. Next slide, please. This is the Toxoplasmosis. We are quite familiar with this because when I was a student, medical student, I've seen many of the advanced HIV case with CNS toxoplasmosis. But with post-AIDS era, in those with immunocompromised, sometimes we see toxoplasmosis in case of the transplantation. I've seen CNS toxoplasmosis in kidney transplant patients before, and it's pretty hard because by the time the patient had the diagnosis, he had to undergo brain biopsy for that. And toxoplasmosis is generally a foodborne illness and can be transmitted through feces of the infected cats, or it also can be contaminated through the undercooked meat or vegetable. And again, human to human transmission can be seen through blood or organ transplant. And the prevalence of the infection actually in general population is high, up to 50%. Most patients are asymptomatic. Next slide, please. Toxoplasmosis in immunocompromised host is lethal, and symptom can be fever, and then patient can progress to multi-organ involvement and or disseminated infection. And most reported cases, or about 82%, were due to primary infection and presented in the first 6 months post-transplant, often with pulmonary infection or disseminated infection. Sometimes the patient was missed as heart failure until the biopsy of heart done and they identified the tachyzoid in the tissue. Next slide, please. This is an example of kidney transplant patient who actually unfortunate unfortunately died from the toxoplasmosis. He actually did not get bactrim prophylaxis, but got pentamidine prophylaxis for PCP. Then within a month after transplant, he suffered fever and hypotension. The biopsy was done and showed that there were Toxoplasma gondii in heart and also in lungs. Next slide, please. This is the, again, table illustrating the treatment which is available in Clinical Transplantation 2019. Next slide, please. And this is the mode of transmission. And you can see here that there are several, pathogen, parasitic infection can be transmitted to all of the modes except for malaria and babesia. The two actually transmit to blood as well, but the most those other parasites were not frequently seen as blood transfusion related. Next slide. This is the pre-transplant screening that can be done for these parasites. Serology is available. We can do serological screening in recipient and perhaps in donor. For elementary parasites, we can also do serology for strongyloides and for some other parasites. For example, in Thailand, there are a panel of the serology that can be done, and we can send it to Department of Tropical Medicine, the Faculty of Tropical Medicine, Mahidol University. Elementary parasite can also be screened through stool, ova, and parasites. Next slide, please. Pre-transplant screening is very useful because it allows us to have the appropriate measure to eradicate the parasite before transplantation, for example, strongyloides. And for Trypanosoma cruzi, post-transplant infection surveillance for those at risk of donor-derived or reactivation disease is also useful. You can also do PCR for that. For Toxoplasma gondii, post-transplant prophylaxis is very useful, particularly for those with Toxoplasma D plus R minus, and it's been shown to give so much benefit for heart transplant patients. Next slide, please. And again, with use of the prophylaxis for Toxoplasma, one need to be careful about duration because the optimal duration and optimal agent is to be determined. But protocol for target donor screening in high-risk regions can prevent transmission of the infection with Leishmania, Plasmodium and Babesia species. Next slide. This is the therapy that also you can see our review in the Clinical Transplantation 2019. Next slide, please. So in conclusion, incidence of parasitic infection varies depending on geographic location and host factors. Infection can result in high mortality, particularly if the diagnosis is delayed. Therefore, the knowledge of the potential pathogen involved, their geographic distribution and transmission, diagnostic methods used, and the recommendation to minimize the risk of transmission during transplantation and of infection in post-transplant periods is essential. With the increase in international travel and transplantation abroad, our understanding of parasitic infection in solid organ transplant will continue to evolve. Thank you.
Hi, Dr. Siriorn. Thank you for the excellent talk. I think we have a couple of questions for you. First question is from Dr. Amira. On the cases that you shared on the strongyloides, Microsporidia, and Cryptosporidium, do you get a sense that they are related to the steroids post-transplant, or were they donor-derived?
I would say first for strongyloides, because we have so much, we have quite an experience for strongyloides. I don't think many of those strongyloides case post-transplant is donor-derived in our experience. We've seen case of the de novo infection mostly were from acquired the acquisition after the transplant from the risk of the patients walking through their own, walking at their home and then get infection, newly acquired infection from that. Because we don't do universal prophylaxis for strongyloides, we only do target prophylaxis. So I would assume that if we see donor-derived infection, we should have seen some cases in Thailand as well. But that's not the case for my practice over 15 years. Besides strongyloides, for crypto and microsporidium, I think it's possible because we never really try to explore the different organs, and we don't really do tissue biopsy for all organs before the transplantation. So I think it's possible explanation for those who probably had actually explant for some other reason that we never identified before. So for microsporidium, I think it's the hardest because for diagnosis, you need good PCR or also staining. And even in Thailand, it's not widely available. We probably missed microsporidium case, unlike strongyloides or cryptosporidium, where we can identify from the simple staining.
Thank you very much for that. Another question also on the strongyloides again. Some of these patients have ongoing risk for strongyloides. Do you screen them, or do you have some ways of picking them up because they may or may not be symptomatic?
Good questions. I would say that because at this time I practice in a kidney transplant center where when there's strongyloides seropositive case, they would send all to infectious disease. So we get to see cases like that. Interestingly, case with eosinophilia before transplant, we try to dig through this and identify cause of eosinophilia. We don't really see that in strongyloides. Those with positive strongyloides pre-transplant do not usually have eosinophilia at presentation. But what we found, and we've been trying to accumulate more data, is neptosomiasis that we've seen. We've seen more neptosomiasis from cases with eosinophilia pre and post-transplant. So it's quite important to keep in mind that eosinophilia is not only strongyloides that can be the cause, but something else as well. For picking up the case, I would say it's quite challenged because in my practice, patient would come to see us frequently in the first 3 months after transplant. So we get to see the patient probably weekly in the first few months, and then later on, the patient come in every month. So we probably miss some patients who actually go back home and live not in Bangkok, and they probably suffer from infection that we don't know, and we miss that. But many of the time, if they are sick, or particularly those in Bangkok, they come into the hospital. But in my practice, I would say I see strongyloiditis post-transplant maybe once every 1 to 2 years. It's not quite common here in our center.
Thank you, Dr. Siriorn. I think that's all the time we have for questions. Thank you very much for the excellent talk.